Dear audience, I'm Dalma Tábi and I'm currently working at the Department of Community Dentistry as a clinical dentist, and I envision as a PhD student that most of the children with disabilities have a good oral hygiene and they have access to a high quality treatment if needed. To achieve this, my mission is to provide them a specialized preventive dental education program to improve their oral health knowledge and their cooperation during the treatments. Now I have two running projects. In the first one, we are investigating if these school-based oral health educations are effective at all in a meta-analysis, and in the second one, it's a pilot study for a randomized clinical trial when we provide this specialized education program for children with special needs. As we all know, bad oral hygiene is a major public health issue, and it can affect all age groups, especially children. And one of the solutions is oral health education, when we can improve their oral health literacy by focusing on the preventive care, and the aim of this method to find the most effective methods. We included studies when they compared two groups of children in a school-based prevention programs. The intervention group received this education, and they had a control group who not received the education during the follow-up period, and the both group attended an oral health examination before and after the intervention. Our hypothesis is that children receiving the school-based oral health education will have better oral health indices, and that's why we included several outcomes to measure it. In our systematic search, we used 4 domains, one for the population, 2 for the intervention, the location and the synonyms, and 1 for the required outcome. In this way, we had more than 8,000 results. It was a broader search key because after the selection, we could include only 33 articles to the data extraction. In the plots, you will see that we compared the changes of these oral health indices. So the changes from the baseline to the follow-up periods. And in the tables, if there is a minus value, that means that there was a reduction in the values, and if there is a plus sign, it means that we had an increment in that part. In the term of the DMFT, we have found a minus 0.06 mean difference between the intervention and the control group, and it was not statistically significant, and it was not clinically relevant as well, because in the terms of the DMFT, it can be measured from 0 to 28, and the value refers to the number of the patient's decayed, missing or filled teeth. We had high heterogeneity in almost every cases because of the design features of the studies, such as the age group and the duration of the intervention. That's why we made several subgroups. Here you can see that we made subgroups based on the provider of the education, but we couldn't find difference between the teacher-led and the healthcare worker-led groups. In the case of the oral hygiene index simplified, we have found a mean difference of minus 0.56, which is significant difference. And we have found a difference between the teacher or oral healthcare worker-led groups and when they used other methods such as videos or short drama acts, for example, because they were less effective. We could see changes in the bleeding and probing index because in the intervention group there were 1% more reduction in the teacher and healthcare worker group. Changes in the Silnes-Loewy plaque index is also significant because we have found a 0.25 mean difference between the two groups. And it's clinically relevant too because we can measure this index on a scale from 0 to 3, and the higher the index, that means the person has a poorer oral hygiene. We have made a fifth figure, and here you can see just the raw values of the oral hygiene index simplified at baseline, at 6 weeks and at 6 months, and we can see that at the baseline we had quite high indices, but after the intervention there were a great reduction, and after several months the oral hygiene index simplified is increased again. That's why we need to redesign these prevention programs in childhood with several revision occasions to achieve that maintaining a good oral hygiene become a habit of the children. The strength of this meta-analysis is that we use just RCTs with different educators, and we included long and short-term outcomes to investigate the effects. But on the other hand, the heterogeneity was really high, and it was almost impossible to objectively compare these interventions. And because of the time frames, we do not have enough data to compare all of our studies in a long term. Our conclusions that these educations are effective in short terms, although there are many ways to educate and it can affect the effectiveness of the education, and there are implications for the research that we need longer follow-up periods in RCTs, not just like 1 or 2 years with these indices, but for example decades. We need to standardize the used indices because you could see that now there are many indices and we can't compare really these interventions. Now I'm done with all of the task and I'm writing the manuscript. As I mentioned, our second project is a pilot study for an RCT when we are investigating the effectiveness of a dental prevention education program for oral hygiene among children learning in conductive pedagogy. It is an important topic because children who are medically compromised has worse oral hygiene than their healthy peers, and their DMFT values are 2 times higher. That's why we need to provide them a dental preventive education program as well. We had a population at the Pető András Institute, so we took advantage of the opportunities offered by this institute, and we had the same group, one for the intervention who received the education, and one for the control group who did not receive the education during the follow-up period. And we measured their oral health indices before and after the intervention, and our hypothesis is that this 8-week prevention program results better in oral hygiene, and it improves their cooperation during the dental treatments, which is very important too. We included all the children. Our main criteria was we included only who returned the consent form signed by their parent and the guardian. And in this way, we could gather about 20 children from the 90. So we had a small group, and we excluded the children with serious mental retardation. The first 2 groups, so the pilot study has ended on Monday, and now we are gathering together the data, and we would like to make a proper statistical analysis then, and write the protocol involving more schools and to design a real RCT with more schools and more children. I would like to thank you your attention with a quote that you have to go back to the beginning to understand the end by Tábi Altman. Thank you very much.
I have only one question. You said that the used indices should be standardized in a way. Do you have any suggestions which ones to use?
Thank you for the question. Yeah, it's a great question because most of the studies use the DMFT and the DMFS indices to measuring the oral health of the children, but based on the WHO suggestion, it should be measured in every 5 or 6 years, although the study only included a 1-year follow-up, so there were no significant difference because of it. So my suggestion would be that we should use the oral hygiene indices in this case if we have a shorter follow-up period.
I have one question about your second topic, which is how do you plan to control for the different severity of the mental health of the children based on which program are they receiving or education?
Thank you for your question. In this case, we, as our experience, we could only educate the children with no mental health problems or with mild problems, because who have these severe mental illnesses or disabilities can be educated in this way, and that's why when we are treating them we use general anesthesia, because they are just can't cooperate in the way we would like to. So we try to involve them for several cases, but we had difficulties with the children who just have mild problems with their mental health. So it wasn't easy. We had only 2 groups, and it was a mixed group based on their skills. So it was hard, but we are trying.
Congratulations for the presentation. You mentioned that only mildly challenged children are more easy to educate, but for more challenged children, are there programs to perhaps educate their parents that can help in their oral hygiene?
Yeah, we would like to educate the parents, guardians, and the conductor as well, but in these institutes there are not children with these hard disabilities, because they are excluding them too, because of the education they provide. Thank you.
But most of the children have physical handicaps as well.
Yes.
So, and according to their age, the youngest population should be taken care by the parents, so they brush the teeth, right?
Yes.
So how can you compare eggs to apples?
Yeah, yes, that's the beautiful part of educating children, that it's really hard to compare them based on their skills. And based on our experiment, not the motor part are important, so the movement disabilities, but the mental. So for example, we use so-called GMF-CS scale. It's a growth motor function scale to categorize these children. And for example, I'm in the first category, but children in a wheelchair is in the 5th category. And we have found that all of them needed some help from their parents. Unfortunately, it was an unmet need, and they don't really receive the real help from their parents. And we try to make it equal with the help of the conductors, for example.
Yeah, but as the dentist recommendation, we used to tell to the parents until age 8, 9, they should brush the teeth of their children anyway, so that's why.